presentation, which will be given by Gherardo Finocchiaro from London in circumstances of sudden death in hypertrophic cardiomyopathy, data from a large pathology registry.
Thank you very much, Professor Brugada. It's a pleasure to be here. Ladies and gentlemen, I have nothing to declare. So the association between hypertrophic cardiomyopathy, fatal arrhythmias, and sudden death has been observed more than 50 years ago. But we still struggle to stratify the risk of sudden cardiac death in these patients. But some progress has been made. The ESC has developed guidelines for the management of hypertrophic cardiomyopathy patients, including a calculator of the risk of sudden cardiac death that identify risk factors that may be useful in stratifying the risk in these patients. However, the role of sport and of exercise as a trigger for the development of fatal arrhythmias is still unknown. And also, we don't know what is the rate of exercise-induced sudden cardiac death in these patients. The guidelines recommendation from both sides of the Atlantic suggest that patients with hypertrophic cardiomyopathy should not compete in most competitive sports. So with this study, we try to investigate the demographics and circumstances of sudden death in a large cohort of sudden death victims with hypertrophic cardiomyopathy. And also we try to assess the risk factors for exercise-induced sudden cardiac death in hypertrophic cardiomyopathy. So when there is a sudden unexpected cardiac death in the United Kingdom, the case goes to the attention of the coroner and of the local pathologist. The local pathologist can refer to our cardiac pathology center, which is an international recognized cardiac pathology center in the United Kingdom. Not all the cases are referred, but many cases of sudden death are referred to our center, mainly because of the expertise, the particular expertise in sudden cardiac death. So in the last 20 years, we were able to assess more than 3,600 patients, and out of these, 184 were hypertrophic cardiomyopathy. All the patients were investigated, were assessed with a very strict and thorough protocol, including macroscopic and histological analysis. And also we had information from the coroners and from the local pathologists about various clinical features, not only about demographics, but also about past medical history and circumstances of death. And these are the characteristics of our populations of sudden cardiac death victims with hypertrophic cardiomyopathy. So we see that the average age was 39 years old. There was a predominance of male gender, and the majority of the patients died at rest or during sleep. 81% versus 19% died during exertion. If we look at the histopathological features, we see that the heart rate was, as expected, increased, and left ventricular fibrosis was present in 59% of the patients. If we look at symptoms, we see that the majority of patients were asymptomatic prior to death, 78%. And among the cardiac symptoms, palpitation was the most frequent. Also, we see that a diagnosis at post-mortem, only at post-mortem, was prevalent, 80%, while diagnosis during life was made only in 20% of the cases. We looked also at the predictors of exercise-induced sudden cardiac death, and we see that young age and male gender were independent predictors of exercise-induced sudden cardiac death. So to conclude, sudden death in hypertrophic cardiomyopathy occurs frequently in asymptomatic patients, and in patients where the diagnosis is unfortunately not made during life. Sudden death in hypertrophic cardiomyopathy often occurs at rest or during sleep. And young males constitute the category at higher risk of exercise-induced sudden death. We need more studies, randomized studies, that should assess the benefits and harms and risk of exercise in patients with hypertrophic cardiomyopathy. And lastly, the early identification of patients with hypertrophic cardiomyopathy, even in asymptomatic patients with screening policy, for example, with electrocardiography, is key to properly stratify the risk of sudden death. Thanks for your attention.
Thank you, Professor Huber. Some comments?
That's a great analysis. And so what is the conclusion then? So first, if you know that the patient has hypertrophic cardiomyopathy, I know some professional sportsmen in Austria that then have an ICD, or they are protected by some kind of a device which is with them, or with a trainer or with a doctor. But if most of them develop the problems during sleep, so is there any indication to use more ICDs in these patients?
Well, I think that probably we still struggle to stratify the risk of sudden death in hypertrophic cardiomyopathy patients. So, of course, in 20% of our cases, a diagnosis was made in vivo during life, and maybe this patient may have been saved. But these patients were considered to be at low risk by the current guidelines, the current risk stratification calculator and risk factors. So it's really difficult to say. Maybe there should be other risk factors that may be considered for the stratifications of these patients. We know that there are patients that unfortunately die suddenly, even if they have just 0 risk factors or just 1 risk factor. So this in some way is a snapshot of a failure of the current recommendation about stratification.
Two comments. One is, this is a long study because it started in '94. Yeah. And it has changed a lot the way we're treating the patient with hypertrophic cardiomyopathy, and we have learned a lot, and certainly we have a lot of information from Italy on reduction of sudden death during sport activity after identification and excluding patients with hypertrophic cardiomyopathy to perform a sport. So we have been trusting this information until now, and we are all, when we see a patient with hypertrophic cardiomyopathy, we stop him from sporting, and we have the feeling that we are helping him. So here you have 20% of the population that had already the diagnosis before dying suddenly, and we don't know, as you say, whether in this population, if we have stopped the sport activity in this population, we have a spare sudden death in them. Also, the question is, you might see it in the reverse way. See, 1 out of every 5 patients dying with hypertrophic cardiomyopathy was sporting. So it's not only 20%, it's 1 out of 5 that was dying during sports activity. So we might prevent 1 out of 5 deaths. We don't know. I mean, but we trust the data we had until now. So now, questioning completely the role of sports in hypertrophic cardiomyopathy now, I think this is a little bit dangerous, because we don't have the information to say that because only 20% die during sports and 80% die at rest, they can sport. I don't think that this should be the conclusion.
Yes, you make definitely a very good point. I think that an important observation, however, is that there seems to be a particular category that is at higher risk of exercise-induced sudden cardiac death, and this is the young male. Of course, we have an increasing number of veteran athletes, both males and females, and also we have females that seems to be at lower risk in general of sudden death, but particularly of exercise-induced sudden cardiac death. So I think that maybe this data can help in tailor the guidelines, the recommendation, to some specific categories, some specific subgroups that may be at higher risk. So maybe the recommendations are valuable in these individuals, but may not apply to all individuals with hypertrophic cardiomyopathy. This is the speculation.
Please.
Two questions. Could you associate this either through medical records or family reports with obstructive sleep apnea, either contributing to the hypertrophic cardiomyopathy or to the event? And second of all, going forward, will you look at other possible interacting factors like genetics?
Okay, so the first question, we had a very low proportion of patients with sleep apnea, a very low proportion of obese or overweight patients in our cohort. So, of course, it's an important point because of the association with arrhythmias in these patients, but apparently from our cohort it seems to be a very low rate of sleep apnea. About genetics, another very important point. So, as we know, there are increasing data about molecular autopsy, and we are studying this aspect in our group and also considering our pathology registry. Unfortunately, molecular autopsy is a relatively new technique, and as we have seen, the cohort include patients in the last 20 years. So we have some preliminary data on molecular autopsy, or at least we have the spleen for further analysis, for the genetic analysis, but we don't have any data at the moment about genetics in these patients.
Any other comment, question? Thank you very much. So we move